there is abnormality seen in the left humeral head with some absence of the humeral head contour and quite severe abnormality seen on the glenoid part as well. There is superior subluxation of whole of the humerus and with an abnormal pseudo articulosis type of appearance. There's also erosion seen at the lateral end of the clavicle on the same side. The bony density is generally reduced on the left side, most likely due to some diffuse atrophy. On the contralateral side, there is normally visualized humeral joint and humerus, etc., clavicle and bones. Soft tissue, I cannot appreciate any asymmetry in any breast tissue. There is some apical haze seen in the right apex region. Neck soft tissues are normal. I cannot appreciate any abnormal reticulonodular shadowing in the chest. And the heart is normally visualized. So I will like to take the history in this patient if the patient has any previous surgery or any history of any previous imaging to rule out syringomyelia, but that would be more of a bilateral case, or it could be some advanced case of tuberculous arthritis. I would like to compare with the previous and will go accordingly. I believe that instead of systemic, it is more of a localized process.
Right. So, as far as surgery is concerned, there is no history of surgery. The patient has got shoulder pain, and it is actually a bilateral finding, clinically speaking. Do you see anything on the right side?
On the right side, there is some superior subluxation. The
Look at the
clavicle
AC joint. Look at the AC joint.
AC joint is abnormal. Um, Actually, coracoid is normally visualized. The acromion is quite lucent, and there is degenerative changes in the acromion as well. So it is possible that it could be due to a long-standing syringomyelia. I would like to see the MRI if available, sagittal to see tonsillar herniation, any spinal cord abnormality,
So,
or a
what
simple.
comes to your mind other than syringomyelia?
Other than syringomyelia, uh, if the I would like to see the vertebrae. Sir, can you change the window a bit? I'm like I would try to see the any H-shaped vertebra
There is no
or
H-shaped vertebra.
sorry.
There is no H-shaped vertebra.
Okay. Then it can be possibilities are with the lateral erosion. It can be secondary to hyperparathyroidism, any chronic renal failure, or partial. No, cleidocranial dysostosis is not like this. So
Mhm.
it can be due to bilateral humeral deformities.
If you
Yes,
are
yes,
worried
sir.
about If you are worried about syringomyelia, then how do you explain the finding at the AC joint?
Uh, at the AC joint, yes, syringomyelia is more of a bilateral process. It is symmetrical and it is more giving like a Charcot joint type appearance with the debris density deformity. And there is also, although there is deformity on the left side, but there is no increased density, and it is more like a bilateral superior subluxation. So it, it can be due to any chronic renal failure, hyperparathyroidism. These are all I
Patient,
can think
patient
about.
also has got multiple other joint pains.
Multiple other joint pains. Sir, can I see the hand radiographs of the patient?
So with this history, what comes to your mind?
It can be bilateral advanced osteoarthritis or any
Okay, thank you.
hemophilia is more likely to involve knees, and hemophilia is less likely a possibility. Rheumatoid arthritis normally involves the small joints more rather than shoulders.
Okay.
So I would like to give a bone survey to see
Thank you.
rest of the
Thank
joint.
you. Thank you. Right. So this was your case one, and this is rheumatoid arthritis. And this is exactly why I was showing it because, distribution of joints, unusual presentation of a common condition, and things like that. So please remember that rheumatoid arthritis can involve uh, actually practically everything, any joint. Uh, but if you see here in your Chapman, there is a differential diagnosis, erosion or absence of the outer end of clavicle. Rheumatoid arthritis is one of them, typically bilateral and symmetrical. So the joint involved is the AC joint. With that, the shoulder joint can also be involved, and I'll show you cases to explain that further. Other than that, hyperparathyroidism, as well as some congenital conditions such as cleidocranial dysplasia and pycnodysostosis, will be in our differential because this was a bilateral finding. Now, this is another rheumatoid arthritis case where this is from Radiopedia, and we can see again, if you see there is erosion here of the lateral end of clavicle, and look at the shape of the head of the humerus and how it is affected. You can also see superior subluxation. Please remember that in long-standing rheumatoid arthritis, secondary OA changes is a secondary finding which can happen in any joint. So there are secondary OA changes, but look at the head of the humerus. Now, other than that, just to show you differential diagnosis cases, this is bilateral symmetrical, same uh, erosion of the lateral end, and this was a case of hyperparathyroidism. Of course, in the exam, when they will show you, they might show you with some other stigmata. On the other hand, they might show you a second film and things like that. This is a case of renal osteodystrophy where we can see generalized increased bone density, and you can see erosion at the edge of the film. This is edge of the film case where just here you can see it, and renal osteodystrophy is the same thing as hyperparathyroidism. Of course, there will be other findings, generalized increased bone density, etc. So then two things in the differential diagnosis, both of them are congenital dysplasias. I think in the last session or last to last session, I did show you cleidocranial dysplasia, and I told you that whenever you see a cleidocranial dysplasia case, you have to discriminate it with pycnodysostosis. Both of these can present with erosion or absence of outer end of clavicle, and then both of them will have Wormian bones in the skull. But in pycnodysostosis, the mandible is small. On the other hand, the in cleidocranial dysplasia, mandible is normal, by the facial skeleton in both of these conditions is small. So normal mandible in cleidocranial dysplasias, and more importantly, in pycnodysostosis, you will see bone sclerosis, which you will not see in cleidocranial dysplasia. So these four things, pycnodysostosis, cleidocranial dysplasia, hyperpara, rheumatoid arthritis, other than all of these, are most important for your exam. This is the case of cleidocranial dysplasia where you see absence of clavicle bilaterally, and these are Wormian bones. You can see that the midline ossification is actually deficient, so pubic symphysis will be widened, and this exam can start from here, from the pubic symphysis, because in cleidocranial as well as pycnodysostosis, this finding will be there. Look at the mandible, and mandible is normal. This is another case of cleidocranial dysplasia where you can see, look at the clavicles and they are absent. Look at the pubic symphysis, how widened it is, but look at the clavicle, the mandible, and the mandible is normal. And of course, the bone density is also normal. This, on the other hand, is cleidocranial dysplasia or dysostosis, in which the clavicles were absent. But if you can see, so Wormian bones are there. Wormian bones are bones within the sutures of the skull. But more importantly, if you see the base of the skull, if you see the orbital margins, you can see sclerosis. And then look at the mandible. The mandible is smaller. So this mandible is a very important differential between the two. Now, this film will tell you what happens in RA. RA can involve the shoulder joint or the glenohumeral joint. So what is happening here is, if you see, the clavicle is completely missing, so it is eroded already. Then there is superior migration of the head of the humerus in relation to the glenoid. And then because of mechanical effect, there, the glenoid is impinging here, impacting here, and there is a bony defect there. There is superior migration, means there must be complete tear of the supraspinatus. So you can well imagine then in very long-standing cases, there can be erosion, and this is what I was showing you in that case which I showed you. Here, another case from Radiopedia, where you can see lateral end erosion. Look at the head of the humerus, and you can see this erosion. It is completely ill-defined. Now, you got confused because of Charcot joint, and that was a very good call. But please remember, in Charcot joint, because of syringomyelia, AC joint will not be involved, number one. Number two, actually, your thought process was good, so I'm talking to you, candidate one here. Your thought process was good, where you thought that the head of the humerus here had a sort of a pseudo-surgical type of defect. And your thought process was very good, where you were trying to rule out any bone debris and sclerosis, etc. Please remember that in Charcot joints, what happens is, these are the 5Ds: increased bone density, joint diffusion, bone debris, cartilage destruction, joint disorganization. So the joint uh, will be the bone density will be normal, or there will be sclerosis, and there can be debris here. So because of this appearance, I think there was a bit of confusion. So our case was actually rheumatoid arthritis. Let me go through the findings in the case, and then we will go to the next case. So if you see here, there is AC joint, complete erosion from here to here, it is eroded. On the right side also, there is a bit of overlap, so it is a bit of a confusing finding, but actually look at the acromion and there is a big gap here. So there is erosion at the AC joint. There is superior migration even on this view, which is not optimal view. And so there was a finding of actually bilateral. So this kind of defect can occur. Actually, I forgot to show you an elbow case, which is with me in my collection, in which, everything is eroded of the adjacent bone. So please remember that long-standing rheumatoid in long joints can cause you this kind of finding. As far as chest is concerned, there were some incidental findings, but I am not interested in anything in the chest in this case. Okay, well done. Your thought process was good, except that rheumatoid arthritis, you ruled out rheumatoid arthritis for reasons which, uh, just one second. Okay, candidate one. This
Yes,
is a
sir.
case from A&E. This is a 35-year-old male, severe headache and vomiting, unwell
Okay.
patient.
Sir, should I request for control?
Yes, please.
Sir, I have.
The control is with you.
Okay, sir. Um, mm, okay. So this is axial CT brain imaging in a patient who presented with in A&E with emergency symptoms. I will like a moment to go through entire stack of the images and then I will start commenting. So my first observation is that in this plain study, there is a heterogeneous density lesion is seen in the right temporal lobe with hyperdensity in its margin. Lesion is well defined, no associated edema, and a focus of hypodensity within it, and also leading to type of air fluid level type of thing. And there is, however, I'm trying to rule out any adjacent uncal herniation or tonsillar herniation. Wait, I think there is a kind of mild uncal herniation which is leading to compression on the adjacent midbrain region. The soft tissue outer to the temporal bones are normal, so I don't believe that it is due to some trauma. There is effacement of the sulci on the right side with compression of the ipsilateral lateral ventricle, and there is some hyperdensity seen in the region of superior sagittal sinus, which might be projectional or might be related to the lesion. I will next advise contrast enhanced study, and also there is some loss of insular cortex is also looking abnormal. So, sir, I will advise MRI with contrast for the patient to see any adjacent uh, transverse sinus is also hyperdense on the right side. So I will like to advise MRI with contrast for this patient to rule out sigmoid and transverse sinus thrombosis with
This is 2
associated
o'clock in the
abscess.
morning.
Sorry, sorry, sir. Sir, hello, sir.
Sorry, I think there was a internet breakdown, which is a very rare event. I'm sitting in the hospital. So there was an internet breakdown. Let me make co-hosts once again. Candidate 1, 2, 3, 4, 5. Candidate 1, can you hear me?
Yes, sir, I can.
Okay, so I'll show you the case once again. So candidate 1, the point is, you can hear me?
Yes, sir, I can.
So, you asked for an MR, and I was asking you that this is 2 o'clock in the morning. Will you do an MR?
No, sir. First, I will like to see the bone window or any other window
So the
to.
first step is, okay, let's see the bone window. Let me give you the bone window. Just 1 second. This is the bone window. Over to you.
Okay, in the bone window, I'm going to see the region of temporal bone because I observed hyperdensity in the region of sigmoid and transverse sinus. So in the region of there is a soft tissue density region completely opacifying the middle ear cavity as well its posterior part. Mastoids are hazy and completely opacified. There is some air foci seen within the intracranial cavity as well, which is consistent with the air fluid level, which I saw at the same region. Sir, can I see the coronal section to visualize the erosion of the roof of the midbrain to see the direct communication of
Okay.
the.
This is the coronal.
Yes, I want to see the direct communication of the or extension of the infective process into the cranial cavity. Uh, there is, I'm trying to look for roof. Yes, if we compare both sides, I believe that this is the tegment tympani region and it has been eroded. So, or you can say that it has been multiple foci of absent bone are seen in the roof. So, and yes, adjacent to it, an ear is seen. So, it is likely uh, acute middle ear infection with mastoiditis with extension into the brain parenchyma leading to a temporal lobe abscess with adjacent right sigmoid and transverse sinus thrombosis. I need to urgently inform the findings to the referring physician because I also suspected some uncal herniation at the same level. Next, after the initial management is over, I will advise MR venography following it. But firstly, the patient needs to be treated urgently for this intracranial abscess and transverse sinus thrombosis.
How can you confirm this?
Confirm, sir, with HU at this level, or I can zoom. I can zoom the image.
Anything else?
I can go to lung window.
The patient is in from A&E. What can you do at 2 o'clock in the morning to rule out? Do you diagnose sinus thrombosis on plain films?
Mm,
How can you confirm it?
sir, by taking the density or some altered window level.
Okay, so the answer is that you simply do a post-contrast scan. Simple as that.
Sorry.
Yeah, please now look at this. This is post-contrast.
Okay. Yes, in the post-contrast images, uh, there is some more more enhancement of the meninges on the right side. Also, I would like to go to there is air in the level which I suspected, and there is a filling defect or in the right transverse sinus, but
Where is the
there
transfer
is,
sinus?
sir, not transverse sinus. There is this sigmoid sinus. It is showing expansion with loss of normal filling. So it is
Show it, point
sigmoid
it out to
sinus
me.
thrombosis.
Point it out to me. Where is the sigmoid sinus thrombosis?
Sir, this one,
Mm-hmm.
this one.
Okay. And what else is happening?
What else is happening, sir? There is some adjacent dural enhancement of the cerebellum, which can be early cerebellitis, or I should also see the internal jugular vein for its lower extension. Mm,
Look at the parenchyma, anything else in the brain?
Anything else, sir? There was a suspected abscess. Sorry, the image is held. I
Okay, just
cannot.
one second.
Should I request the remote control once again?
Now, can you see the image?
Yes, sir, I can.
Okay, just conclude the case now.
Sir, so it is acute mastoiditis with intracranial abscess and adjacent sigmoid sinus thrombosis with uncal herniation and early cerebellitis.
Okay, thank you. So this is the case on which I'll do a bit of teaching. So so uh, this is mastoiditis with brain abscess. Right. So before I might, because I'm going to do a half an hour teaching on this one, I might forget the feedbacks. Candidate one, are you with us? Candidate one?
Yes, sir, I can hear you.
So the first point is keep it simple. You have to ask for the simple thing first. In 2 o'clock in the morning, you don't ask for an MR, number one. Basic thing is, change of windows, things like that, bone window, that is basic. And then to do a post contrast is this is what we do in any case in emergency. So ask for this. So these were two feedbacks for you. So think like you are in an A&E scenario and how are you going to tackle this? Second thing is that uncle herniation, and we will come back to that. Sigmoid sinus thrombosis, etc. So now this is differential middle ear lesions. Look at the word middle ear lesions, and this is what the case was: acute otomastoiditis with abscess. And usually clinical will be otalgia, otaria, fever, hearing loss, etc. You will see opacified mastoid hair cells, cortical and trabecular erosions. There can be epidural or brain abscess, and there can be venous sinus thrombosis. So the mandate today is to see the or revise the anatomy of the temporal bone, and next time I'll show you more cases of temporal bone so that the concepts are uh, uh, you know so the concepts become absolutely clear. Now, and they solidify. This is the temporal bone. Temporal bone has got various portions. One of them is this squamous portion of the temporal bone. This is the middle meningeal artery. Interestingly, this is the thinnest bone in the skull. And that is why people come with fracture of this bone and with epidural hematoma when the middle meningeal artery or its branches are perfed. On the other hand, there are, tympanic portion, stylomastoid. This is another portion, the stylomastoid process. This is the mastoid portion. But we are interested in the petrous part of the temporal bone. If you see the surrounding bone anteriorly is the sphenoid bone, and here is the occipital bone. In between, if you see, this is a pyramid. So this is the eminence of the superior eminence or arcuate eminence of the petrous part of temporal bone. In between the occipital bone and the petrous part is the jugular foramen, and we'll come back to this. Within this is the IAM, the porus acousticus, or the internal auditory meatus. And then the carotid artery also passes through it. Please remember that jugular foramen is not a foramen within the temporal bone. It is in between the bone and the occipital bone. So with that background, if you see, these are the nerves. To develop the concepts of anatomy of temporal bone, one of the best method is to develop it around the seventh nerve. And this is what I do. So we will go through it, and you will see at the end of this, you will be more confident in your imaging of temporal bone. Because I did not have time right now to ask the candidate questions, but I could have asked more questions, pointing out that what is this, what is this, what is this, and expect that to happen in the exam, anatomy wise. So here we can see that this is the jugular foramen, anterior part of the jugular foramen. This is known as pars nervosa, where the ninth nerve passes, and then the 11th and the 10th nerve, they pass through it, and the jugular vein is also passing through it. Here, the seventh nerve and the vestibulocochlear nerve, these two are passing. This is the internal auditory meatus. Other than that, if you see now, this is the transverse sinus. It dips down here. This is the sigmoid sinus, and then it becomes the jugular vein here. And the jugular vein now it tells you that jugular vein is passing through the posterior portion of the jugular foramen, uh, and anterior portion, the ninth nerve is passing. Here, the 10th and the 11th nerve, they pass through it. One point to remember is that the hypoglossal nerve, which is the 12th nerve, has got its own canal, and as soon as they pass into the neck, they come together within the carotid space. So another view here. So this is the transverse sinus, then is the sigmoid sinus, and then is the jugular vein. On the other hand, within the temporal bone, the internal carotid artery has got its course and it passes through it to go into the cranial cavity. So there is a vertical portion and then there is a horizontal portion. Ultimately, it ends up in the cavernous portion of the internal carotid artery. If you see this overview, the coronal view, we can see that this is the external auditory canal and this portion is the middle ear. So we are interested in the middle ear. But then on the medial side of the middle ear is the internal ear. So let's see it in more detail. Now, now this is the middle ear, this is the internal ear, and this is the external ear. Now, this portion of the middle ear uh, is known as mesotympanum. So this is the tympanic membrane. There is a big landmark of bone here, which has got this pointed appearance in a coronal. This is a landmark in imaging of temporal bone. This is known as scutum. And then there is this part which is known as tympanic annulus. So the tympanic membrane is attached here. With that is the first ossicle, which is the malleus, then is the incus, and then is the stapes. I'll come back to the anatomy of the ossicles in the next slide or the slide next to that. Coming back to a more global view, if you see here that this portion of the middle ear cavity, which is in line, if you draw an imaginary line from here to here and here to here, from here to here will be the mesotympanum. Superior to that will be the epitympanum. And this thing here inferiorly is the hypotympanum. Hypotympanum actually contains nothing. And you can also develop this concept that mesotympanum is the room and hypotympanum is the basement, and this is the attic, which is the epitympanum or the first floor, whatever you want to call it. Now, as far as internal ear is concerned, internal ear, we have got a cochlea and we have got a vestibule. From the vestibule, we can see lateral semicircular canal, superior semicircular canal, and posterior semicircular canal, which is not visible here. Now, this is the lateral semicircular canal, which is very well seen on imaging on a CT scan. And this is a landmark. And they will, if they show you cases, particularly of cholesteatoma, etc., they will ask you, what is this? What is this? Now, another take-home point here is that the facial nerve canal is passing inferior to the lateral semicircular canal. So this is a point to remember. This is the lateral semicircular canal. This is the facial nerve, it is what we call the tympanic portion, which is passing inferior to that. Coming back to the epitympanum, the head of malleus actually joins with the body of the incus here. We'll come back to this point. But superior to that is this plate of bone, which is known as the tegmen tympani. And this is where the erosion was, and the candidate one picked up very well this part of anatomy. Inferior to the hypotympanum at the base is the jugular foramen. Anteriorly to this, which of course cannot be seen on this diagram, is the carotid canal. Posterior to that is the adductus ad antrum, which is the connection between the epitympanum and the mastoid air cells. So we will repeat this again and again, and in the end, it will be a consolidated anatomy which you will get. Now, these are the ossicles. So these portions, the lateral process and handle of the malleus is attached with the tympanic membrane. But key point, which is seen very well on a CT scan, is head of malleus, and this is body of incus. This is very well seen on imaging, and they will show you cases of incubomalleolar dislocation on a CT of trauma of the brain, and it is visible on normal actually brain windows, not window, brain imaging. Just look at the bone window. And so this portion, the head of the malleus and the body of the incus is within the epitympanum. However, this portion is the long process which dips back into the mesotympanum. Here it joins with the stapes. So this is the stapes. This is the incudostapedial joint, and on CT scan, even this can be picked up and its dislocation can be picked up. I don't think so at a FRCR level they will show you, but they will show this dislocation to you. Stapes is the smallest bone in the human body. This is the anterior crus and this is the posterior crus, and you'll be surprised that this is only about 0.58 millimeter in thickness, and it is visible on our CT scan where we are doing a 0.625 slices. This is the foot plate of the stapes, which is attached with the oval window of the cochlea. So coming back once again, mesotympanum. This is the mesotympanum, which is in line with the tympanic membrane, hypotympanum, epitympanum, external ear, middle ear, tegment tympani, and then the brain. Inferior to that is the jugular vein or the jugular foramen. And then this is the cochlea and this is the vestibule, and only two, this is superior and lateral semicircular canals are visible, and this is the facial nerve which is visible. Now please concentrate, because whole of the concepts can be learned very well around the facial nerve. So what happens is, in a global sense, this diagram is a schematic diagram. It's not anatomical diagram. So remember that, but it will tell you what I want to tell you. I want you to remember. The seventh nerve, the facial nerve, comes out of the pons. It goes into the internal auditory meatus. This portion, which is passing through the temporal bone, is known as labyrinthine portion. It goes anteriorly. Here is a ganglion, which is basically a bit of thickening of the nerve. This is the geniculate ganglion. There is a nerve which goes anteriorly, greater petrosal nerve, which deals with lacrimation. Uh, so it from here it turns back like this, turns back on a sort of a U-turn type of an appearance. This is the tympanic portion. Tympanic portion is the nerve which this tympanic portion is what you are seeing here, inferior to the lateral semicircular canal. So this is the tympanic portion. It goes along the medial wall of the mesotympanum, goes posteriorly, and then it dips down, vertically down. This is the mastoid portion or the vertical portion. At the stylomastoid foramen, this is the stylomastoid foramen, it comes out of the base of skull and it ends up in the parotid gland. Please remember, at the parotid gland, then it divides into branches. So I will next session, I will show you more concepts of anatomy and various kinds of cases around it, which can come in the exam. So uh, if you see, concentrate on this axial diagram, and this is a beautiful diagram to explain what you will see on a CT scan on an MR. Anteriorly, this is the internal ear. So anteriorly is the cochlea. I call it the flower. It looks like a flower. Actually, you can see it. So flower is the cochlea. And posteriorly is the vestibule. Vestibule has got then superior semicircular canal, lateral semicircular canal, posterior semicircular canal. So three canals are there. Now, see the nerves which are coming out. The nerve which comes out from the cochlea is the cochlear nerve. It comes out into the internal auditory canal, or I should say that it is going from the pons and then goes into the internal auditory canal and meatus through the canal into the cochlea. Superior to the level of the cochlea is the seventh nerve. So this is the seventh nerve. And see, from here till here is the labyrinthine portion. Actually, you can see it here where I'm pointing out. This is the IAM, and this filling defect is the labyrinthine portion. Anteriorly, this is the geniculate ganglion, and this is the geniculate ganglion where my mouse is. From there, it turns on itself, passes posteriorly. This is the tympanic portion. It passes posteriorly, inferior to the lateral semicircular canal. So this is the lateral semicircular canal, beautifully seen on a CT scan, and it passes posteriorly. Here you can see this linear line, which is the facial nerve canal. Then it passes backwards and then it descends down. It descends down and you can see it. I'll show you a CT scan axial to show it to you clearly. Coming back, in this portion, if you see, it comes down and then it descends down like this. On a sagittal, it gives you this appearance. We call it a hockey stick appearance. Uh, so other concepts about facial nerve, etc., I'll tell you in next session, cauda tympani and taste fibers and etc., etc. Now, with that concept is MR anatomy. This is a cis axial and a cis sagittal oblique view of the temporal bone, where we can see four nerves here, four nerves. This is the cerebellum, this is posterior, this is anterior. So we can see four nerves, one, two, three, four. And one of my students, one of my registrars, years ago, she got in her viva, the examiner actually, this is how the case was opened. The examiner opened it on a sagittal oblique like this. So if you don't have this idea, you will be absolutely lost. And the classical question is that what is what? So what is coming back, here you are. This is cochlea. So the cochlear nerve is coming out. This is vestibule. Two nerves come out, superior vestibular, inferior vestibular, and superior to that is the facial nerve. So the formula is 7 up, coke down. So this is 7 up means facial, superior, and this is the cochlear nerve, superior vestibular, inferior vestibular. So this is the anatomy of the IAM on a MR. Once again, a repetition of what we have learned till now. Place yourself here in the middle ear cavity. On the right side is the tympanic membrane. So this is the lateral wall. This is the medial wall. Here is the cochlear promontory. The cochlea is projecting here. Here is the semicircular canal. Here is the facial nerve canal. Add to that the ossicles. Superior to this level is the epitympanum. The encodomalleolar joint is in the epitympanum, a landmark on CT imaging. The incudostapedial joint is within the mesotympanum, and this is the stapes. This is the hypotympanum. Inferior to that, of course, will be the jugular foramen. Superior to the tegmen tympani will be the brain. So this is the medial wall. This is the cochlear promontory, lateral semicircular canal, facial nerve. This is the lateral wall looking from inside. And we have got the tympanic membrane. This is the epitympanum, head of malleus, incus, and this is the incudomalleolar joint. So let's see the anatomy on an axial bone window. First of all, let's have a global view. So this is axial and I am going from inferior to superior. So in my view are mastoid air cells, which can be variable, please remember. So first of all, we will just have a global view and then we will have a more detailed view. Here is external auditory canal. Anteriorly, there is a the TMJ, the temporomandibular joint. Now, on the other hand, if I go back, you can see that this is the clivus. This is the petrous apex. In this patient, in the petrous apex, you can see air cells. Please remember that this is variable, and there will be patients in which it will not be pneumotized. We call it pneumotized. It might be solid. So so don't confuse if you don't see any air cells. Within that, now if you see here, I am going back once again. Sorry, I am going down once again. Here is the carotid canal. So this is the vertical portion. This is the internal carotid artery sitting here. And then will be the horizontal portion. You can see it here, horizontal portion. And then it will go to the cavernous portion. Here you are. So into the cavernous sinus, etc. Now, with that overview, let's go back to our friend, the facial nerve. So first of all, orient yourself. The landmark here is cochlea, the flower. This is the flower. So medial to the flower, if you can see that the pons will be sitting here. So this is the internal auditory meatus and the canal. So from the flower, the nerve which will come out is the cochlear nerve. Now go superior to the cochlea. So I am now going superior. Here you are. As I go superior, you can see this linear line. So this is the facial nerve. It goes anteriorly, and you can stretch your imagination. If you know your theory, you can make your anatomy. Here will be the geniculate ganglion. And from the geniculate ganglion, it will turn on itself. So before we go to the facial nerve, you can see actually the lateral semicircular canal. Look at this one. This is the lateral semicircular canal here. And coming back to the facial nerve, now it will straighten up. It will become a line. This is the middle ear cavity where I'm pointing out, because this is, and this facial nerve passes inferior to the lateral semicircular canal. It goes posteriorly. And there is a bit of fine touch of anatomy which I'm not overloading yourself right now here, but this is known as the pyramidal eminence. But now it is going down. Just see the arrow. This dot is going down, and this is the internal auditory canal. This is the TMJ. It will go out of the base of skull. It is going down, 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 down. And finally, we go into the stylomastoid foramen, and then we come out of the skull. Stretch of imagination. This is the mandible. So the parotid gland is sitting here. So it will go into the parotid gland and will then, that will be, the final branches. So coming back, this was the facial nerve. Once again, quickly, let's see. Labyrinthine portion, geniculate ganglion, then the tympanic portion passes inferior to the lateral semicircular canal, passes posteriorly. When it reaches posteriorly, then it dips down 90 degrees. This is the mastoid portion or the vertical portion. It is going out, 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 and ultimately out of the stylomastoid foramen. So now let's concentrate on the coronal scan. And please remember that those of you who are sitting your part 1 exam, this is classical. Some of these, what I am showing you, are classical for your exam. They will show you the same thing. Now, on a coronal, this is the IAM, internal auditory canal and meatus. So the seventh nerve, now this is the cochlea. This is the cochlea. So what happens is that the seventh nerve comes in where the arrow is. Now, this is a classical owl eye type of appearance. One dot here, cochlea here. And this is an exam type of a scenario. This is the labyrinthine portion, and this is the tympanic portion. And if you see, it comes out like this, and then uh, it will go anteriorly. So this is the ganglion, and now it is coming down, and it will pass where? It will pass inferior to the lateral semicircular canal. You can see this dot. This is the lateral semicircular canal. This is the superior semicircular canal. And it continues like this. Ultimately, it reaches back and then it dips down vertically. It dips down like this vertically, and then here it will be the parotid gland where it will end the terminal branches. This is also seen on a sagittal. And on a sagittal, the key point here is once you become experienced, you might not see the sagittal, but initially you love it because the descending portion, the mastoid portion appears, gives you this hockey stick appearance, stick appearance. Look how it is going down. And this is the stylomastoid foramen. So this was a bit of anatomy, and we will actually develop this anatomy in the next session further, vis-a-vis the exam. So the cases which I show you are cases for the exam. Please also remember, FRCR exam is not subspecialty level, but whatever I am teaching you, you have to know. And there is more. If you are a head and neck radiologist, then you might like to know more. Now, this section here is now let's just concentrate on the ossicles, the middle ear. So this is the internal auditory canal, sorry, the external auditory canal. And now actually you could see the stapes here, but I'm going into the epitympanum. Here, this is the head of the malleus, this is the body. And if you can see here is this hourglass appearance. This portion where my mouse is, where I'm pointing out, this is the editus ad antrum. So this is the mastoid antrum, this is the editus ad antrum, and then this is mastoid air cells. As I go superiorly, you can see this canal where I'm pointing out. This is the superior semicircular canal. Now, look at the ossicles on a coronal. This is favorite of the examiners. This thing here, this pointed structure is the scutum. This is the head of the malleus, and this is what the body. The space. This is a very important exam scenario. The space in between the scutum and the malleus, head of malleus, in the epitympanum is known as Prozac space. Prussak, Prozac space. And cholesteatoma, for pars flaccida cholesteatoma, usually sits there. It's the most common site. So the point is that this word should be in your vocabulary. I'll show you. So this is the Prozac space where a cholesteatoma sits. And so, of course, this is the vestibule, this is the superior semicircular, this is the lateral semicircular, this is the cochlea. So this was a bit of anatomy. Now, uh, do you want to do a quick quiz? If you want to do a quick quiz, uh, the best method will be that I'll show you a case. Uh, I think all of you should have a pen and pencil. And on that case will be labeled 1, 2, 3, 4, that kind of a thing. For your own, just see what it is, write it down. I'll give you 30 seconds on each slide. And then I'll give you the answer slide. Are you interested? Let me know. Are you interested in quiz? Okay. So please remember repetition. Repetition is the name of the game. More, it is quality, right? It's not quantity. So you repeat, 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 and then you consolidate. So let's do a quiz, right? So I will temporal bone quiz. So I have got four axial sequences. This is 30 seconds. Time begins. 30-second, it is self-explanatory. Last 5 seconds. Okay, so you can check your answers. I'll just point them out. And sometimes what happens is that the human element is that the arrow might not be at an optimal position from your perspective. So don't be harsh on that. Otherwise, this is the petrous apex, and this apex is nemotized. This, of course, is the clivus. Here is the end of the vertical portion of the carotid canal, and then it will become horizontal. This is the external auditory canal. And you can see actually the tympanic membrane here. And this is the middle ear cavity. These are the mastoid ear cells. And this is the jugular foramen. Jugular foramen, there is a concept of high riding jugular foramen where it can be at the level of the mesotympanum, and sometimes the bone here will be dehiscent. We call it high riding dehiscent jugular foramen. In any case, let's go to the next one. This is your second axial, 2 by 4. Time begins now, 30 seconds. Last 5. So just a bit of, because we are going in sequence, it becomes easy for you. This is clivus. This is still the carotid canal. This is the petrous apex. This is the mandibular condyle. This should be one of your review areas when you are reporting a CT of the brain. This is the external auditory canal. You can see the tympanic membrane. This is the middle ear cavity. This is the jugular foramen. Next, please. Time begins. Last 5 seconds. So now, if you stretch your imagination, you can see the stapes here. Actually, the technique to see the stapes in your day-to-day practice is that slightly change window. Instead of classical bone window, make it slightly soft tissue and you will see it better. But you can stretch of imagination, you can see it. So this is the vestibule, and anteriorly is the flower, which is the cochlea. This is the mastoid ear cell, and here is the facial nerve canal, which is the mastoid portion. So this is the descending portion of the facial nerve canal. This is the last one, last axial. Time begins. Last 5 seconds. So anteriorly is the cochlea. This is the vestibule. This is the internal auditory canal. This is the head of the malleus. This is the body of the incus. But the arrow actually was in the air, which is the black space. This space is known as the prozac space. This is the exam space. This is very important space because cholesteatomas sit here. And this is the lateral semicircular canal, which is visible here. Okay, now let's go through coronals. Time begins now. 30 seconds. Last 5 seconds. So this is the solution. And this is a very important exam scenario. You know, two dots, owl eye appearance. This is one eye and the second eye. This is the inner one is the medial, the labyrinthine portion, and this is the tympanic portion of the facial nerve. And this is the head of the malleus. This pointed bone is the most important bone, the scutum. And of course, this is the cochlea. Okay, time begins. Last 5 seconds. So once again, this is the cochlea. These are the same eyes, owl eyes. This is the labyrinthine portion. This is the tympanic portion. Same, the black space is the prozac space, and this is the scutum. I think this is the last one. 30 seconds. Time begins. Last 5 seconds. So here is the superior semicircular canal. The lateral semicircular canal is partly visible. The dot inferior to that is an exam dot. And this dot is the tympanic portion of the facial nerve canal. Of course, the vestibule is here and the internal auditory canal is here. Oh, actually, one was left. So this is a continuity of the previous one. So again, superior semicircular canal, lateral semicircular canal. This dot here is the facial nerve canal, and this is the vestibule. This is the internal auditory canal. And okay, this one, I'll just give you 5 seconds. Just concentrate on 2 and 3. 2 and 3. So the 2 is the facial nerve canal, the mastoid portion or the descending, and this particular opening is the stylomastoid foramen. The lateral semicircular canal is visible. So this is a sagittal in which the only point to remember is that, this gives you that hockey stick appearance, and this is the descending portion, and this is the stylomastoid foramen. Right. So today what we have learned is we have learned a bit of anatomy. We have learned automastoiditis. Next time I'll show you more cases of temporal bone, a bit of fine touch of further anatomy. And if you attend the next session, then you are not going to run from a CT of the temporal. And CT of the in your exam, cases like automastoiditis, which I'm showing you, foramen tumors, which go into the tympanic bone, because it is part of the base of skull. So these are important for the exam. And even in your day-to-day practice, many people run from them. They don't want to report them. And the key thing is anatomy. So if you know your anatomy, you can actually uh, attempt it very well. So next session will be critical for you to consolidate. Okay, so this is a classical exam type of scenario. Even on a soft tissue window, we can see that. So I have not given you the bone window, but you can see destruction here. This was a 12 years old with acute mastoiditis with dural sinus thrombosis, venous sinus thrombosis. You can see a soft tissue abscess. You can see a filling defect in the sigmoid notch. You can see a filling defect in the transverse sinus. So this is classical exam case, just like the case which I showed you earlier today. And this is a similar case where the patient has got 34-year-old fever and headache, and you can see anteriorly, look here, there is a bony defect, and there is an air bubble sitting anteriorly, air bubble in the intracranial portion. Look here, this is the bony dehiscence and complete opacification. So on MR, what we see is that there is meningeal enhancement here. You see, these are the leptomeninges which are enhancing. If you see on the T2 weighted sequence, we can see high signal. When you see, high signal on a flare or T2 without any abscess, you can simply call it that this is cerebritis. This is a generic term which we use, cerebritis, um, with evidence of meningitis here and with dural venous sinus thrombosis. So these are the classical exam cases because examiners are interested in what we call the complications, particularly. So complications of head and neck conditions, uh, like infections, are extremely important for your exam. So let me go through the case itself. So initially, the candidate did very well. We are picked up some on this window, something happening here with a air fluid level. Now, I think the uncle herniation with was a bit of an overcall because there is asymmetry. If you see here, this is the posterior clinoid process. This is the posterior, and there is asymmetry. And by the way, something there has to be trans then there will be, uncle herniation or transtentorial. So that was an overcall. Candidate one, are you with us?
I'm here, sir.
Okay, so that was an overcall, and because that was because of asymmetry. Otherwise, you did pick up the findings very well. But then you overcalled it. You said that there is high density here in keeping with you were absolutely sure. You cannot be sure. You ask for contrast. And on contrast, this is the contrast. Actually, here we can actually see, uh, here you are. Now, this is so here you can, here there is a filling defect. This is a sigmoid sinus thrombosis. But more here, you were not moving your mouse, you just got caught up. Actually, what is happening here? that there is an epidural abscess also in this region. So you could have asked for a coronal, etc., just like your day to day. Think as if you are reporting it in your day to day. And do you see that there is an epidural abscess here? You can see a bit of gas. So there was an epidural abscess with sigmoid sinus thrombosis. Otherwise, you did well. And as far as anatomy is concerned, uh, so this was well picked up. If you see the anatomy which we have learned, so in this particular case, because of time factor, I did not ask everything. But if you see the ossicles are also attenuated. They are a bit eroded. And then there is tegment tympani dehiscence, and here if you go posteriorly you can see it very well. It was actually picked up by the candidate. So with automastoiditis there is sigmoid sinus thrombosis and there is an epidural abscess. Subsequently the abscess was drained and we have got a post contrast. So here the has been drained and we can see, still, but this is post drainage actually, just to make up a point that there was a bit of enhancement here. But this is not for the exam. For the exam is that acute finding. Okay, good. So this was the teaching bit of the today's session. So now we are going to change gears. Okay, candidate one, otherwise you did well. Candidate
Thank
two.
you, sir.
Yes, sir.
Okay, candidate two. So this was a female with a 75-year-old female had a previous stones, 20, 30 years ago, and the patient presented with hematuria. Ultrasound was normal. They asked for a CT urogram. I'm showing you an excretory phase of CT urogram. Concentrate on pelvis, please. I'm interested in the pelvis.
Okay, sir. Okay, I'm provided with the CT scan axial, portovenous phase, excretory,
Excuse me, this
pelvic,
is a
excretory.
excretory phase of a CT. Can you tell me how is it obtained technique-wise? CT urogram.
So first of all, the contrast is injected, and then after 60 seconds, the portovenous phase is obtained, and then after 3 to 5 minutes, the delayed phase is
It
obtained.
doesn't work like that. It doesn't work. It's other way around. So, so what a CT urogram is the phases. You can stop scrolling and just listen, everybody, because this is an exam scenario. In CT urogram, you have to do a non-enhance. It's a compulsion. Must do that. After that, inject contrast and wait. You have to wait for about 8 minutes. But in just 70 seconds before the 8 minutes, inject another bolus. When you do the scan at 8 minutes, this is known as split bolus technique.
Bolus. Yeah.
Part of it will be in venous phase, and
Mm.
part of it will be in excretory phase.
Yes.
And basically, you have saved a phase. You have saved radiation, right?
Yes. Yes.
Oh, please continue. Just concentrate on pelvis.
Okay, sir. So this is the excretory phase, and I will scroll down till the pelvis. Okay. Sir, so I can appreciate that the contrast is specified in the urinary bladder, which is partially distended, and then I can see that there are multiple um, phlebolyths can be seen, and ureters. I will now trace the ureters. Um, So there is non-opacification in the so the right ureter is not opacified from its mid portion, and the left ureter uh, is also okay. So I would I will trace the left ureter once again, and okay, this is the left ureter, and as I scroll down,
Okay, so I am not bothered about the KUB. We could
okay,
not see anything. Anything else you see?
sir, urinary bladder is partially distended with no leakage of the contrast through noted through it, and then there are some sort of strandy the loss of muscle mass on the right as compared to the left, and of the gluteal muscles, and mm, so again, there is some heterogeneity noted in this region, in this region, in the ischial region. So this appears to be soft tissue, ill-defined soft tissue mass, and then lymph node, multiple pelvic and perineal lymph nodes are also appreciated. So I would like to review this in. Okay, so there is a asymmetry and then soft tissue mass, right, sitting here in the ischial and perineal region, and it is also related to the coccyx, the bones, the pelvic bones, the inferior pubic ramus, and the ischial spine. So they are unremarkable. I would like to review them on the bone window as well, and. Sir, I would like to review the coronal images as well to look for the ischial fossa
Ischial fossa.
and ischial region, yes, sir.
Okay.
Okay, sir, these are the coronal, coronal images, and I will scroll again, and would- sir, okay, sir, uh, in the left hemipelvis and along the left ischial fossa, an ill-defined heterogeneous soft tissue mass lesion is noted, and which is um, so it is closely abutting the surrounding rectum with ill-defined fat planes with noted it with at places. Sir, I'm concerned about some soft tissue mass here, and I
What
will
will you do next?
advise. Sir, I would advise MRI for further evaluation and histopathological pathology of this region.
Okay, so here is the MR. Over to you.
Okay, sir. Now I'm provided with MR of the similar region in which I can appreciate that. Uh, okay, I will first of all I'll go down, and then so there is altered heterogeneous asymmetry, and then altered heterogeneous soft tissue lesion. These are the T2 weighted images, and it is appearing hyperintense upon T2. And I would like to review it on T1 post contrast and fat sat images as well. Uh, Fat sat and T1 post contrast images.
Right. So uh, I don't have a T1 contrast, post contrast. I am showing you another T2 here.
Okay, this is the sagittal T2 weighted images, and so this is a soft tissue uh, heterogeneity with okay, these are the phlebolyths which were seen previously. Sir, is it some vascular malformation as a lot of phlebolyths
How can
and
you confirm this?
Sir, I can confirm this. Sir, a simple way is to do an Doppler ultrasound, and other is to
What will
do.
be the finding in Doppler?
So there will be blood flow in this region.
And then how will you label it then? What will it be?
Sir, this is likely a slow flow vascular malformation with multiple with phlebolytics. Sir, it's likely a slow flow vascular malformation.
Are
Like,
you sure that these are phlebolytics?
sir, these I'm talking
How can
about
you
the.
confirm them?
Sir, on I have seen them on CT.
Okay. Okay. Good. Well done. So this is intramuscular hemangioma or whatever, the new classification, of course, calls it slow flow venous malformation, etc. But the word intramuscular hemangioma still is used unless you are working at a tertiary level, and you can use it. So that was well done. Let me go through the case. Uh, so in this case, on axial, we can see this mass with phlebolytics. The only thing is, candidate two, the only thing is that I think you did not go to the last few slices. And so you would have been more confident that it has going into the thigh. So otherwise, you picked up everything, and you did ask for a bone window, etc., which would have maybe increased your confidence that these are flavolates, but overall you did well. Now on this T2, this is a, you know, pathognomic on a T2 weighted sequence. What is the role of Doppler? In this, these are vessels, and these are flavolates here. And in Doppler, the technique is that if you can reach it, these deep ones, of course, you cannot. Basic technique is, and this is what I was asking, you compress them, you press them, and they will be compressed. So that confirms that this is a vessel, and this is vascular malformation and not a mass per se. So that was the question I was referring to. You could have asked for a plain film, and on plain film, which is usually in the exam, actually they want you to say that a
Yes,
plain film.
plain film.
So simple things, and on which will tell you what it is. So actually, I had a case on PowerPoint, which I'll show you with the next slide because of time factor. Let's go to your next case. This is your next case.
Okay,
Candidate
sir.
Q.
Yes, sir. Sir, I'm
This is a
providing.
31-year-old female with thigh and leg pains, hip pains. So they did a few X-rays. This is a pelvis X-ray.
Okay, sir. Sir, I'm presented with the X-ray pelvis, frontal projection of a skeletally mature patient, and the obvious abnormality I can see is that there is a cortical thickening with increase, cortical thickening and sclerosis, with noted along the visualized upper left femoral shaft, and rest of I would now look at the rest of the bones, which are grossly unremarkable. The sacroiliac joints and the bilateral hip joints are unremarkable, and so increased thickening and sclerosis, which is mainly involving the left, but I can also appreciate it on the right as well. But I'm not sure. I would like to review the further X-rays of the bilateral femoral shaft
Mhm.
if they are available.
Okay, so actually, The patient had leg pains also, so they did uh, leg X-ray. Here you are.
Okay, sir. So this is the X-ray left tibia, in which again there is cortical thickening noted. Uh, Sir, I cannot appreciate. I would zoom to look for any periosteal reaction. Sir, I have a suspicion on medial side, but I'm not sure because of the image clarity. And so there is increased thickening and of the cortical thickening, with which is also causing
What would you
reduction
like
in
to
the.
do? What would you like to see?
Sir, the other limb, the right limb as well. Okay.
So, so this is the
Yes, sir. So this is the AP and lateral projection of the right tibia as well, in which I can see that the similar cortical thickening is noted. Along with that, a metallic fixator is seen, and okay, on the right tibia as well. So this is some diffuse process which is involving the bilateral tibia and femora as well, with cortical thickening. And sir, any other X-ray I would like to review if
these are the
available.
only ones available. What do you think is happening?
Sir, I would like to compare them with the any previous X-rays if available, and the history of the patient. Sir, I would like to advise metabolic work. Her age was 31, right?
She is 31, yes.
Yes, okay. So young patient with the cortical thickening, which is diffuse. Um,
Which area is thickened?
Sir, the diaphysis is thickened.
Okay, so can you conclude now?
Sir, it's not involving us. It's so myelorhistiocytosis can also can be one of the differential, but it's not giving the classical candlewax appearance. And
Sources will be on one side.
yes, sir, it will be on the one side as well, sir.
Yeah.
Sir, any other osteopetrosis, but it is also not the case. It is as it is involving the diaphysis only.
Mm.
And
So your thinking process is good, but I think theoretically speaking, you don't remember this thing actually. But you're basically, this is a sclerotic bony dysplasia, right?
yes, some sclerotic bone dysplasia.
But okay, so let me take over. You've done well, but the word was not in your mind.
Yes,
Now
sir.
we
Yes,
see what the mind knows, isn't it?
yes, sir.
So by the way, this is a hemangioma case which I had not shown you. I'd forgotten, so I'm just showing you quickly. In this case, if you see here, there is as if aggressive changes happening in the bone in the fibula. The key thing is the flabellets. There are flabellets. And this was actually reported as an aggressive tumor disregarding the flabellets. And this is why it becomes a classical exam case. Look at the flabellets, 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 flabellets. Here is aggressive lesion. And on imaging, so this was the imaging in which we could see the same, fluid filled on a stir sequence. If you look carefully on the, how it is invading, this is the fibula, how it is going into it. It is infiltrative, though it is benign. And again, if you do a Doppler, you can see fluid levels inside. But phleboliths is the key. And please remember, phleboliths are your saviors. Phleboliths are also in a completely different context in varix of the orbit. You have to ask for that to be able to pick it up and things like that. So phleboliths, don't be afraid of asking for a plain film. This is another one, 7-year-old soft tissue hemangioma. Now, this is Engelmann's disease. So the thought process was good, but of course, because it has not been seen, the name did not come to the mind. This is what we call, this is generalized increased bone density in a child, and there is a spectrum. And let me show you this slide and we'll come back to this. What is the spectrum? Spectrum of sclerotic bony dysplasias. They take a picture of this. And all of these are exam cases. Please remember, all of these are exam cases. All have come in the exam. Poikilosis, which is very, very simple, has also come in the exam. So osteopetrosis, pycnodysostoses, diaphyseal dysplasia is what I have shown you. The name tells you that it is diaphysis which is involved, also known as Camurati Engelmann's disease, Melourhiostosis. And so if we come back, this is it, osteopetrosis, pycnodysostate, whatever, but this is diffuse symmetrical cortical thickening and diaphysis of long movement. So and melourhiostosis is, dripping candle wax appearance, which is usually on one or more bones in a single limb, So this one word will be so helpful in your exam. Please remember that all of these things, once a patient becomes an adult, these things will persist. Basic issue is that these dysplasias are because you remember normal bone modeling is dependent on osteoclastic and osteoblastic activity. So either the osteoclasts are not working well or the that kind of a thing happens and there is a spectrum. So uh, this is osteopetrosis, and in osteopetrosis there is bone within bone appearance, which can be curvilinear in the iliac blades and bone within bone appearance in the skull. This is melourhiostosis, where you can see in the same limb in the tibia as well as the femur. There is what we call dripping wax, molten wax appearance, end ostial as well as periosteal. Remember that. End ostial means inside the medullary cavity. Periosteal means outside. Will give you this kind of appearance. This is melourhiostosis, and this is another case from radiopedia, Engelmann's disease, diaphyseal dysplasia, bilateral symmetrical. And this is osteopoikilosis. Basically, you are seeing now in short cases, by the way, it should be a favorite short case. This time, there have been short cases which are not difficult, but then you have to write quickly, whatever, and etc. We will, I think, do a session on short cases someday. But the point is that just remember that these will be linear or lanceolate or rounded uh, bone islands, which you will see along the long axis of the big joints, osteopoikilosis. So Engelmann's disease, it begins in childhood and follows a progressive course. And please remember, they can cause pain. They can cause other symptoms and because the skull and spine can also be involved, then they can cause compression of the foramen, etc. And the most common bones are femur, tibia, fibula, humerus, ulna, and radius. So the long bones, but skull and pelvis can also be there. Epiphyses are spared. Okay, candidate two. Your two cases are done, isn't it?
Yes, sir. 2 cases are done.
Okay, you've
Thank,
done well. Well done.
thank you, sir. Thank you.
Okay, let's go to candidate three. Candidate three, are you with us?
Yes, Doc.
Okay, so here you are. This is a case which came into the hospital, 85 years old, and new symptoms of confusion. So the patient is very confused.
Okay. Can I ask a remote control?
Yes, please. Yeah.
Okay. I've been provided with axial cuts MRI for a brain for a patient complaining of confusion. Just I will have a rapid scroll and then I will comment. Okay. This is a FLAIR sequence. I can see that there is abnormal hyperintense signal in the deep white matter and centrum semi-oval, more in the right aspect of the brain, especially the right parietal and the frontal temporal lobes. Okay. And also it appears to be in the left aspect, especially in the left parietal lobe. Okay. Okay, sir, can I see another sequence for this?
Which sequence?
I want to look for diffusion, and also I want to look for post-contrast.
This is diffusion.
Okay. Just 1 second. Okay.
So when you go, it is going out. Scroll to the other. Yeah.
Okay. Okay.
Let me, okay, set it for you.
Okay.
Now, scroll this.
Okay. In diffusion, all these lesions.
Just 1 second. Actually, the point is that these are stacked together. So let me show you. This is a low B value, right? I'm
Yes.
scroll for you. This is a low B value, a sort of a T2 weighted sequence. And
Okay.
then I am going superior. So this is the highest B value. This is the highest B value.
Okay, I can see that there is some lesions show restricted diffusion.
What else would you like to see?
Just I want to look for if there is any post-contrast.
So you want to see the post-contrast?
Can I see also the ADC to be sure if this is restricted diffusion or just...
This is the ADC.
Okay, and the ADC, it appeared to be hyperintense also, so I couldn't see it low intense signal, so it appeared to be T2 shine through only, not restricted diffusion. Okay. So this patient coming with...
Ask me the sequence.
Okay.
I told you the patient has got confusion, new onset confusion.
Okay. So this multiple hyper intense signal in T2 and in FLAIR and non-restricted diffusion lesions. Can I see if there is any contrast enhancement for this?
This is the contrast, and the patient moved a lot, but I am showing you, I am scrolling for you.
Okay.
I'm going up and I'm coming down.
Okay. I can see that there is here restricted, there is contrast enhancement, maybe in the, yes. It's multiple. Okay. I can see that some of the lesions show marginal contrast enhancement, especially here in the left aspect, in the left low parietal region. Okay. Yes, there is multiple contrast enhancement for this lesion, marginal. I'm
What is
thinking
your
of
conclusion?
this could be infection, could be a source of infection.
Which kind of
Uh,
infection are we talking about?
um, um, I want to know if this patient has any immune deficiency or something.
No.
No immune deficiency. Okay, so this is now multiple lesions scattered through the brain parenchyma with marginal enhancement. This could be multiple abscesses, but there is no significant edema surrounding. It could be white matter lesions, multiple white matter
Just
lesions.
give me your conclusion and I'll then take over.
Okay, this
No.
is multiple white matter lesions noted with marginal enhancement, which could be demyelination like MS or
Okay.
and
Thank you. So this case actually is gliomatosis cerebri. And I'll tell you what it is. Basically, before that, can you hear me? Candidate 3, is it 3? Yes.
yes.
Yeah. So, we always talk about grade 1, grade 2, grade 3, grade 4. And by the way, this concept has gone redundant because in neuro centers, they do a lot of immunochemistry, etc. Having said that, the concept still is helpful at our stage, FRCR stage, so you can still use it histologically. There are four things which they see: nuclear atypia, mitosis, microvascular proliferation, and necrosis. If you've got only grade 1 is a circumscribed tumor, grade 2 has got one of these parameters, grade 3 has got two of these, grade 4 has got three or all of them. Grade 4 is a GBM. So with this concept, it is gliomatosis cerebri is you have to develop your eyes on the pattern of this lesion. And this is diffusely infiltrating glial tumor involving more than two lobes. And it has got a very unique configuration. It can cross through the massa, through the thalamus to the other side or through the corpus callosum to the, so it can be bilateral. It can involve 3, 4, 5 lobes. Now, this is very interesting. Infiltrative extent of tumor is out of proportion to histological and clinical features. It is diffusely infiltrative, and the patient will not be all that. Remember this: patient will not be all that bad as the lesion, and radiologically speaking, the case will not be all that bad looking. Because of this pattern, it will be diffusely infiltrative. And usually it is grade 3, but it can be grade 2. And basic concept is that within the tumor, there will be grade 2, grade 3, and grade 4 type of foci. And another concept is it degenerates. So from grade 2, it will become grade 3. And if you do an interval scan, it will become grade 4. By definition, radiologically, grade 4 means necrosis. And sometimes hemorrhage is also taken. Best diagnostic clue: T2 hyperintense infiltrative mass with enlargement of involved structure. Location: typically hemispheric. White matter involvement may also involve the cortex. Now, this is critical. And this is what we were, the flare sequence was very useful in this case. Flare sequence was just like, herpes simplex and encephalitis type of a thing, where the cortex is involved as well as white matter is involved. This is 19%. But more than two diffuse white matter, basal ganglia, thalami, which is deep gray matter, corpus callosum, brainstem, cord, cerebellum, all of these things can abnorm. May cross through to the other side through corpus callosum or massa intermedia through the thalami. So, and please remember that underlying architecture is preserved. Now, this is a unique thing. So it is infiltrative, it enlarges, but there is underlying brain architecture is preserved. Now, I'll show you a case. This is from my 2015 collection, 10 years ago. And this was initially reported as herpes simplex. And you can understand why. If you see here, uncus here, so the gray matter is involved, the white matter is involved, and then it is going, this white matter, this is a flare sequence, and then it is crossing the corpus callosum. So it has, involvement of the temporal lobe is there, frontal lobe, parietal lobe, corpus callosum, and on the contralateral side, maybe the parietal lobe is involved. And if you see here, at this stage, you don't see anything in this region. But then there were multiple scans, but I'm just showing you this scan, which is 13 weeks down the road. And you can see how it has progressed so fast. So it has, even here, you can imagine that the architecture is more or less, there is a bit of midline shift, but if I go back and show you the initial one, somebody who reported it as herpes simplex, you might agree because it doesn't look all that infiltrative. And by the way, at this stage, it did not enhance. Please remember, after 13 weeks, there was a new focus here. And of course, there is a midline shift, and you can see now infiltration to the parietal and the frontal lobe, and maybe here, you see how it is going. So from here, the corpus callosum, it is going here where I'm pointing. It goes here and goes into the temporal lobe. How infiltrative? It only took 3 months for that. And on post contrast, this is GBM. So this becomes a multifocal type of a thing here. And then there are foci which enhance and show necrosis. Is a rare tumor. By the way, it is not all that rare. So I presented this case because it became a medical legal case in 2015, and at that time, we saw two in our hospital. Actually, there was a lot of debate: is it herpes simplex or not? Clinically, it was not herpes simplex. What is the take-home point? Take-home point is clinical is very important. Treat the patient, not the X-ray. What we teach in our medical school. And in this case, after 6 months, they did a biopsy and then the patient died in 1 month. It became a medical legal because the patient could not have been saved. But if you if a patient has got 6 months of life left versus 1 month of life left, there are many things which can be better tackled. So, peculiar brain correct imaging, diffuse involvement of multiple lobes can either involve white matter or white matter as well as gray matter. Usually it is grade 3, but it can be grade 2 and it can progress to grade 4. Please remember, whenever you see diffuse abnormalities where gray matter and white matter is involved, look, keep it in your mind and go correlate with clinical viral encephalitis, demyelination, vasculitis. And this case, which I am showing you, is only a few weeks old in our hospital. And irony is that we saw another one within the last, I think, 2 months or so. So they come at times in pairs. So bec- My Cyrex is not working. Hello.
Yes, Doc, I hear you.
No, I'm talking to the Cyrex that Cyrex is the software, it's not behaving, so I'm talking to the software to behave. Now I think it is behaving. So now, if you see here, look carefully, develop your eyes on this one. This is the flare sequence. Now ask yourself what is involved. So the gray matter is involved. You see the cortex is involved and the uncus is also involved. And look here, the gray matter and the white matter. It is very infiltrative and it is going superiorly. Usually in white matter diseases like, let's say, demyelination, there can be cortical involvement, by the way, we know that, but not to this extent. But herpes simplex, that, okay, fine, that will be. Look here, how impressive it is. Whole of the gray matter is involved as well as white matter. You will agree that the architecture looks sort of normalish and on DWI sequence, DWI was not, please remember that even gliomas can cause what we call restricted diffusion. And there was a bit of, I think, restricted diffusion here with low ADC. But one thing, candidate three, when you asked for post contrast, you must look for a pre contrast before you look for a post contrast. In this case, there was a hemorrhage. Of course, you could have asked for this, but the key thing is always ask for a T1 pre. When you ask post contrast, then tell the examiner that I also want to see the pre-contrast so that if it is relevant, he or she might show you. So in this case, if you see here, there was a bit of hemorrhage. This is the site where, so there was hemorrhage is also taken as a sign of highly malignant lesion. Key point is that pattern is what I was looking for. Gray matter is involved as well as, if you would have tackled it as, but herpes simplex will not cause this kind of a thing. This is another entity where the eye see what the mind knows. And so it's a unique, if you read a textbook of neuroradiology, there it is a unique scenario. It is, don't confuse it with a GBM. This is Gliomatosis cerebri with a unique type of radiology. Okay, so candidate, this is 3 or 4?
Yes,
3.
3.
So, madam, you did one case or you did more than one?
1.
Okay, this is
1.
your second case and the last case. Over to you.
Okay. This is frontal radiograph, musculoskeletal patients, portable, AB view. Okay, just I will have a look. Sir, what is the history of this patient?
So this is a 54-year-old female and came to the hospital with chest pain.
Okay. I will start checking. Okay. I can see that there is evidence of bilateral reticulations noted within both the lung parenchyma. Both the hilums appearing normal. I can see that there is evidence of left mastectomy, while the right one appearing normal. I couldn't see that there is evidence of pleural effusion. I want to have a look for the bone. In the bone, I want to maybe this rib, just 1 second, I will count it. 1, 2, 3, 4, 5, 6, 7, 8. Maybe the 8th rib in the 8th rib in the right posterior aspect showing I couldn't trace, suggesting that there is maybe a lytic lesion affecting it, and also in the right scapula, right clavicle, there is multiple lytic lesion noted within it, and also in the right scapula. I can see again the same lytic lesion. Okay.
How can you confirm that?
By CT, if I would
Madam,
go for.
think you are reporting this case. How will you confirm it? What will be your reflex? Just X-ray.
From X-ray, okay.
And this is what this exam is about. You know,
Okay.
simply ask for a magnified view, magnify it,
Oh,
change
okay.
densities. Simple as that. And this is what you have to develop your reflexes. Keep asking, you know, simple things. And this is how, whenever, you know, when you report it in your day-to-day, this is what you are going to do. Now,
Yes.
confirm.
Okay. After magnification, it appeared to be clear, more clear.
This is the point. This is the point. Okay. So now you have picked it up. So what is your conclusion?
I believe that this is a case of cancer breast with multiple lytic lesion extending to the bone, and I am also concerning about this reticulations that noted within both the lung.
Reticulation, there's just disregard. That is just projection.
Okay.
So
Okay.
this is a CT which was done with the CTPA protocol of the same patient. And what do you want to see? Just
I want to look for the bone window.
bone window.
Yes.
So I will. So this is the bone window.
Okay, I can see that there is evidence of multiple lytic lesions noted within the right scapula and the right clavicle and the right head of the humerus. And also, I believe that there is some lytic lesion noted within the rib and within the spine, thoracic spine.
Fine. Thank you. Thank you. So this was a simple case. It was an observation case, which you did well. The only thing is you did pick up the finding, but this is what this, you must develop these reflexes of asking, keep it simple. You know, if this is a CT scan, then so that is what this case was about. Nothing difficult. So otherwise you did very well. So just 1 second. So it's simple. Metastasis, there was a, because of time factor, I did not show you, but the point is that you picked up, this is a classical case in the FRCR, which is an observation type of a case. Once you have picked up the mastectomy, you pick up this thing, you pick up, something else, you ask for a magnifying view, you can ask for a change of density, etc. At times, the examiner will do it for you if you want, and you can see that there are so many metastases even here. So this is critical that you ask for it. On this CT, because of time factor, I did not show you all windows, etc. But actually, of course, you would have picked it up. There were metastases in the liver also. So, which was nothing difficult actually. There was metastasis and there were bony metastasis, which you mentioned. So this was a simple case, an observation fail. Thank you, madam. Well done. Okay, next candidate, please. Candidate 4.
Hello.
Yes, candidate 4.
Yes. Yes, sir.
Okay, here you are. This is a
Sir, then
38-year-old female, has got thoracic cage pain.
okay, this is chest radiograph, frontal projection of 30-year-old female having history of chest pain. the density of the radiograph is not clear. However, I am looking at the lung fields. There is no obvious pneumothorax or pleural effusion. Both costophrenic angles are clear. I can appreciate that, yeah, now the resolution is good at some points. I can appreciate that there is a region of a subtle ill-defined opacification along the right pericardiac location.
Look at the bone. Look at the bones.
So actually resolution is very poor. However,
Whatever resolution is, look at the bones.
Okay. There are a few sclerotic lesions along the. I can appreciate right over here in the 1, 2, 3, 4, 5 mid-thoracic rib, mid on the left side, and also.
Anything else in the ribs?
Sir, sclerotic, yeah, on the right side also, these could be due to previous fractures. So actually, again, the resolution is again sometimes.
Okay, thank you. Thank you. You are again and again talking about resolution, and the findings which I want to show you are very much visible. So I'll take over. Thank you.
Okay.
Now, if you see this here, this is a case of a neurogenic tumor. And the key thing is inferior rib notching, and maybe findings around that. And this is the type of case in which you have to develop your eyes. Now, if you see here, this is a rib, this is the rib. Compare it here and here. Look at this distance versus this distance. And you will agree that this distance is increased. Then you look carefully, and there's a notch here. And then maybe something, this distance is also slightly decreased. And this is what this film was about. Inferior rib notching and things like that. When I have given you a hint, look at the ribs, then you should have picked it up. And there is nothing to do with resolution or anything as far as this finding is concerned. Now, with that, if you would have picked it up, I would have shown you this axial. And this axial is a CT scan in which we can see that there is a lesion here. And this lesion, if we can see on a coronal, which one can ask a coronal also. So part of it is causing inferior, this is the transverse process, and this is superior rib notching also. Here you are. So that kind of picture is, you can see, and it becomes a simple case. And then you, if needed, you can confirm it on an MR. And this is the MR. And on the MR, this is it. If you on post contrast, because to differentiate between a solid tumor versus let's say something like a dural ectasia, etc., you can ask for contrast. And in this particular case, where I'm pointing out, there is an enhancement. So this is a simple case, an observation case. Once you pick up the finding, then it becomes very simple. Okay, now I will show you the next case. This is your next case. This is a 69-year-old male ANE. And the patient presented with acute abdomen. Over to you. Just concentrate on the upper abdomen.
Okay,
You can
sir,
ask for the mouse.
I have requested remote control.
Okay.
Okay, these are contrast and NCT axial sections in the portal venous face of 65-year-old male patient having history of, I think, acute abdominal pain, you said. I am scrolling from the top. I can appreciate that there are bilateral pleural effusions more on right side and also in the liver, and there are few low density lesions in the, especially in the left lobe of the liver. I'm going down. I can appreciate that there is a mild thickening of the stomach in the region of the gastroesophageal junction. In the rest of the, there is the gallbladder shows a mild thickening with a small amount of pericholecystic fluid. I'm trying to see. I think there is some discontinuity, and the stomach shows stomach is distended, shows air fluid levels. So confining to the upper abdomen, in summary, in this there is also a mild thickening of the Girota's fascia and lateral conal fascia. So in this patient, there is a right-sided bilateral pleural effusion more on right side, and thickening of the gastroesophageal junction, also diffuse thickening of their stomach. And besides, there are signs of acute cholecystitis with acute inflammation.
Disregard this finding. There's nothing. Anything else?
So of the gallbladder, you are saying?
Yeah, disregard the gallbladder findings.
Okay, there was a thickening of the also the first part of the duodenum, I think, right over here in the region. So this could be, I am looking for any fluid surrounding this in the region of the gastric pylorus.
Madam, can I
Yeah.
stop you there? You don't use the mouse to point to the examiner unnecessary. When you are scrolling, you have to speak what you are seeing. You cannot say that I can see thickening here. Tell him that there is thickening of first part or whatever, things like that. Over to you.
Okay. So I am looking at the first part of the duodenum. There is a slight thickening of the first part of the duodenum, and I can see that there is fluid surrounding it, and also some foci of the gas in the vicinity. In my routine practice, I would like to see this on the lung window to confirm this air outside the lumen. So this could be a case of perforation at the site of first part of the duodenum.
I've given you the lung window.
Okay, I can see a spot of the air in the vicinity of the previously mentioned region of the bowel, that is the first part of the duodenum.
Where is it?
So
point out to me. Where is it?
Right over here.
Where you are pointing?
Some dot. Sorry?
Where you are pointing? Where are you pointing?
So right over here.
Where?
In the vicinity.
This is in the lumen you are pointing out. This is in the lumen.
Yeah, right over here. This one. Can you see my?
Thank you. Thank you. So this is a case of localized perforation of the junction of D1 and D2 segment. The key thing is that uh, if you see here, this is the D2 where I am pointing out. This is the D2, and this thing is sitting outside. So the description has to be that there is a focus of gas which is extraluminal abutting the D1 segment, D2 segment, and then there is surrounding fat stranding. And it is a simple case. So there is localized perforation. Okay, fine. Thank you.
Thank you.
Next candidate, is this the candidate 4? 4. Sorry, 5, isn't it? Candidate 5.
Yes, sir.
Okay, candidate 5. This patient is a 43-year-old, came with fever and confusion. So we have got an MR. Over to you.
Sir, I request the control.
Yes, I've given you the control. Over to you.
Yes, sir. Sir, this is a 41-year old male. I am provided with the MRI brain FLAIR images. I am going from down to upward. First, I will scroll through the image, then I would talk about the abnormality. At the level of corona radiata and right centrum semiovale, I can appreciate diffuse altered signals which are hyper intense on the FLAIR images, which can be represent vasogenic edema. But I can't definitely see any associated lesion along this, and I can't appreciate any abnormality in the rest of the images. Rest of the structures, including midbrain, thalami, brainstem, are normal. Ventricles are normal in size. I would like to see the pre and post contrast images to see any enhancing lesion in adjacent to these at the area of centrum semiovale and corona radiata on right side.
Okay, thank you. Give the mouse, leave the mouse. I'll show you.
Yes, yes, sir.
So pre-contrast is irrelevant. I've given you the post-contrast.
Okay, sir. Thank you. There is pachymeningeal thickening seen along the right side along the front of frontal lobes.
What do you mean pachymeningeal?
So sorry, leptomeningeal, because it is extending along the sulci.
Mm-hmm.
There is patchy enhancement areas seen, which I appreciate on the FLAIR abnormal, which I appreciate on the FLAIR, which are abnormal. These areas shows patchy enhancement like this.
So what is your conclusion?
So it can be a post-infective process, which is causing cerebritis and associated leptomeningeal thickening.
What kind of infective process?
Can be meningitis
What kind of
or
meningitis?
can be bacterial. The other
Mhm.
possibility is granulomatous disease process, which can be sarcoidosis or tuberculosis, but these are not in the favor because I can't see any ring enhancing tuberculomas in this case.
Are rin-enhancing tuberculomas must for
No,
TB?
sir. No, no.
Then
It can be meningitis, maybe tuberculosis. I would
what
advise the rest of the
you
clinical
you have
lab correlation. And
you have talked about sarcoidosis. What else can it be?
so, what are the involvements of sarcoidosis? Are
I am asking you differential. You have said other than
yes, sir.
meningitis, you have said sarcoidosis. I'm asking you what else can be in your differential.
So, leptomeningeal carcinomatosis, but it shows diffuse nodular thickened enhancement and like masses. And the history should be known in that case.
What will you advise next?
Sir, I would advise the clinical lab correlation and CSF analysis of the patient to confirm my findings.
Okay, thank you. These are old cases: neurogenic tumor, schwannoma, inferior rib notching. Case 8 was duodenal perforation. It was peptic ulcer disease. This is TB meningitis. So just a quick recap. Dura and arachnoid together are known as pachymeninges, and arachnoid and pia is known as leptomeninges. And please remember that the vessels are in the subarachnoid space. So they are, pia is inside and arachnoid will be outside. So when you see a vessel, that will be in subarachnoid space. This is your differential diagnosis, which is extremely important for the exam, that uh, what kind of things can cause pachymeningeal enhancement. Infections are there, and there are so many others which it is one of the most important differentials. Uh, and then leptomeninges. Always remember that carcinomatosis versus granulomatous versus meningitis, all of these things, and sarcoidosis should be always kept in the differential because it is known as the greatest, what we call mimicker in neuroradiology. There is another differential in your book, which is sulcal uh, player hyperintensities, and this is what I showed you, and the candidate picked it up very well, so well done. Once you see sulcal high signal, you asked for post contrast. Please remember that one of the pitfall is that subarachnoid hemorrhage, which is no more visible on CT scan, can also show as high signal on FLAIR. So you give contrast, it will not enhance. There is another differential diagnosis, which is close to what we are seeing, is ependymal enhancement, which is common sense. If there is inflammation or a tumor, etc., within a ventricle, you will see enhancement. Now, TB. Now, this is a case of TB. Now, first of all, you must have clear-cut concepts about these words. CNS TB can be just tuberculous meningitis. So the patient might have only enhancement of the meninges. They can be tuberculomas. Tuberculomas classically are like this. They are nodular, but sometimes tuberculoma will develop abscesses and necrosis. So please remember that these are two different things. Tuberculomas usually enhance, but when there is necrosis, then they become abscesses. In this particular case, the tuberculomas are showing enhancement. One of the key thing is key thing is that on a T2 weighted sequence, at times tuberculomas are low signal, and similarly fungal tuberculomas can also be, not tuberculomas, but fungal nodules can also be low signal on T2. Here you can see that the subarachnoid space is enhancing. I'll come back to this finding. Now, there are a few learning points in this case, which is from my collection, in which this was a young patient with TB meningitis. On a flare sequence, we can see a bit of hydrocephalus. And why is there hydrocephalus? When we give contrast, you can see enhancement in front of the midbrain. If you look at the sagittal, it tells you what is happening. Look carefully. This is the pons. Superior to the pons is the suprasellar cistern, and here is the interpeduncular cistern. On a cis sagittal sequence, it is filled up with granulomatous matter. So whole of the subarachnoid space is blocked, and when we give contrast, it enhances. So uh, this is a close-up of the finding which I was showing you. So develop your eyes on this. So whole of the subarachnoid space is replaced. And this is why in the 6th edition of Chapman, there was a differential which is enhancement of ependymal and subarachnoid space. The word was written there, subarachnoid space. And this is to explain it as if whole of there is a canal here, and because there is fuel inside, whole of it is on fire. So this can happen with TB and things like that. This is a CT scan where you can see this enhancement in the sylvian fissure. And of course, there is leptomeningeal enhancement with that. This is the MR of the same patient where we can see that on a flare there is high signal and that enhancement here. And another case of basal meningitis, we can see, look at this rim around the, so this is pia mater, right? And this time the subarachnoid space is not on fire, but there is a lot of enhancement surrounding it. So you can see the spectrum of findings which we can see on TB. So this is an interesting case, which is a trick case because in this case, we have given contrast. And if you do not pick it up that we have given contrast, at times people confuse it with subarachnoid hemorrhage. So if you see the patient has got developing hydrocephalus, key thing is look at the basilar artery, and the basilar artery, this is the basilar artery, and then you can see that there is enhancement. And if you look carefully, then if you go all the way to the top, look at these sulci, and you can see that the sulci are effaced. So even on a CT, there is a bit of a difference because leptomeningeal enhancement, when it is bilateral symmetrical, there is a bit of subjectivity on a CT scan. So this is a case of leptomeningeal enhancement. This case is a good concept case where this was bacterial meningitis. You will not find this finding in each and every case. So don't think that you will see it every time. But if you see here, the pia mater, which is adherent to the brain, is enhancing. Please remember in pediatric radiology, there is a concept of epidural effusions. Subdural effusion. Subdural effusion. So there can be fluid in the subdural space because of infections, etc. And in this particular case, it is not subdural space because it is subarachnoid space because the vessels are inside. So there is no subdural effusion, but this might be an incidental finding of prominent subarachnoid spaces, which can happen and should not be confused with atrophy. So this is leptomeningeal carcinomatosis in another case where on sulci are high signal on flare sequence and then they enhance on post-contrast sequence. Sarcoidosis, the greatest mimicker. In this particular case, you can see a parenchymal granuloma. You can see this pachymeningeal enhancement. You can see infundibular enhancement. So always consider that also in the differential. And this is subarachnoid hemorrhage, which is slightly old subarachnoid hemorrhage, 6 days old, which was not visible on this CT. These are done on the same day, but on FLAIR sequence, we can see some high signal. It should be actually black like this. And if you don't know that there is subarachnoid, you give contrast, it will not enhance, and you've got your diagnosis. So this is sulcal. Okay, well done, candidate. This was candidate 5. So now is your second last case. Again, there is a problem with my software. It is not projecting. Okay, now we are there. So, candidate, over to you. This patient came to the A&E with pain abdomen. So, 45 years old female. Over to you.
This is the X-ray abdomen frontal projection of a female patient, in which I can appreciate a small foci of calcification in the bilateral lumbar regions, which can be in the kidneys or pancreas. Next, I can find the haze, which is displacing the transverse colon inferiorly. And there is bowel gas pattern is non-specific. There is no evidence of free air or pneumoperitoneum. Visualized bones are normal, and rest of the structures are normal. So in conclusion, there are a lot of calcifications seen in the region of the bilateral lumbar regions, which could be due to the chronic pancreatitis, or because they seems in continuity. So less likely possibility they are in the renal area. I would like to see the post-contrast CT of the patient if available. Okay, this is, sir, can I request control again?
Yeah.
Sorry, sir, it's.
Okay, I'm scrolling for you. So I'm going up. Now I'm going.
This is post-contrast CT abdomen photovenous phase, in which I can appreciate the liver is normal. There are innumerable calcifications seen in the distal pancreatic body and the tail. However, the pancreatic head appears normal. These calcifications are also seen in the region of head and body. Pancreatic duct is also prominent. There is no definite mass lesion is appreciated within the visualized pancreas. There is no associated fluid collection or peripancreatic fat standing. There is no evidence of intrahepatic biliary dilatation. There is no evidence of any congenital abnormality like annular pancreas. Visualized kidneys, adrenals are normal. No evidence of free air in the visualized abdomen. I would like to see the lung window to see any free air, and to bone window any bony abnormalities.
So both were unremarkable. What is your conclusion?
So in conclusion, it's a case of chronic pancreatitis.
So why is the patient having pain?
Sir, I can't see any signs of acute pancreatitis in this
Okay,
case.
then. Thank you. Thank you.
Okay, sir. Thank you.
Okay, this is a case of acute over chronic pancreatitis. So once you have picked up calcification, which was well picked up, nobody is stopping you to ask for this. So this is a feedback for now the second candidate that ask for a magnified view. Say that in my clinical practice, and this is what you should do, because in your description you said that unlikely to be renal because of, the point is that it cannot be renal. The point is it is going over the what we call the spine, and you can be absolutely confident. Once it crosses the spine, so ask for this. So this was the main thing. Second thing is that this, I think you use the word displaced. You should not have used the word displaced because this is just normal variant. It is a redundant transverse colon, which can go all the way down into the pelvis. Now, as far as acute over chronic, now you had picked up the finding. Now, uh, the point you had, you had confirmed, should I say, that there is calcification here. Now, if you look carefully, your eyes should be looking at signs of pain. Now, what is happening here? And I would have asked you anatomy question, lateral conal fascia and what is what and things like that. And there is fat stranding. Look at this fat stranding. And that is why I was showing this case, because the findings were there and you had to pick them up. So, and there is fat stranding here. So there is acute over chronic pancreatitis. Another feedback is that you said that there is no pneumoperitoneum, and then you asked for a lung window. So it should have been vice versa. You will say that I want to see a lung window to rule out pneumoperitoneum. So that's fine, but there was a bit of fine touch. Okay, thank you.
Thank you, sir.
Last case, sorry, last candidate 6, are you with us?
Yes, good evening, sir.
Okay, so this is a 41-year-old. He had a midline swelling in the neck. Patient is very claustrophobic, declined an MR, so ended up doing a CT scan.
Okay, so this is an axial CT scan uh, of the neck. I would like to scroll first and then give my impression. Okay, sir. Sorry, the scrolling.
Madam, the patient has got a midline neck problem, swelling. So concentrate on that area, disregard everything else.
Midline neck, okay. Okay, I can see that the thyroid is seen enlarged. The right lobe of the thyroid is seen enlarged. And I can't appreciate the left lobe of the thyroid. Sorry, doctor, is not scrolling smooth with me. Yeah. Here in this area, I can see there is hypodensity seen.
Madam, midline neck. Midline neck is, clinically speaking, what
Okay.
is that? I am not at all interested in anything else. Please
Oh,
concentrate on midnight. There was a swelling, right? There was a
yes.
lump, a nodule, whatever.
Here I can see there is a midline hyperdense area seen and within the anterior to the isthmus of the thyroid. So I'm suspecting this might be is not cystic. It's not. It's appear hyperdense. So I'm suspecting this might be a nodule seen within the thyroid isthmus with enlargement of the right thyroid loop.
What do you mean thyroid isthmus?
Thyroid isthmus?
What do you mean thyroid isthmus?
No, the isthmus of the thyroid.
What is that?
The part between the two loops of the thyroid, the isthmus.
Oh, so you're talking about that. So is there a connection with the thyroid, this nodule?
Let me check it again. No, sir. Actually, it's not connected into the thyroid. Yes, it is in front of the trachea. Yes, this is the trachea. So yes, this is a hyperdense rounded, well-defined nodule seen with anterior to the trachea. I'm thinking this might be ranula.
Ranula.
Hmm?
What is a ranula?
This is the nodule seen within the neck.
Okay, madam. Thank you. Thank you. This is what it is. This is ectopic thyroid. So please remember that sometimes the thyroid tissue is ectopic, and you have to remember your embryology to be able to pick this up. This is from your book, Visceral Space Lesion. So there is something thyroglossal duct cyst, but there can also be ectopic thyroid. Key embryology concept is that actually uh, there is a foramen cecum in the base of the tongue from where the thyroid actually in a fetus, it starts growing from there. There is a duct which is known as thyroglossal duct. This passes through the developing hyoid bone, and ultimately it goes to the pyramidal lobe of the thyroid and then goes right and left. So this is how it descends down. Sometimes this thyroglossal duct remains patent when the baby is born, and even in adults it can present with a cystic lesion. So key thing is that is it a cystic lesion? And please remember, it will always be midline. Superior to the hyoid bone, it will be always midline. Inferior to the hyoid bone, it can be slightly para midline within the strap muscles. So it will be very anterior. Anatomy is key, embryology is the key. So thyroglossal duct cyst is an exam case, and the eye see what the mind knows. and it can be infected. For example, here, and a location tells you what it is. This concept is, this is known as visceral space. Visceral space is a cylindrical space contained in middle layer of etc. etc. Contains thyroid, parathyroid, level 6 lymph nodes, larynx, cervical trachea, and esophagus. So these are the things which you can see. So this is the pyramidal lobe. This is the pyramidal lobe. So this is a case of thyroglossal duct cyst. We can see hyoid bone here, and we can see this cystic lesion. Cystic lesion. It is slightly off center, and it is within the strap muscle, and this is the thyroid. On the other hand, our case was this. This is ectopic thyroid. This is a case from ACR, which non-enhanced CT, and you can see, this is where the foramen cecum is. You can see this high density, and this is the key thing is that even because please remember thyroid has got iodine, and even on a non-enhanced CT, it is slightly hyperdense. So you can see this nodule. When you see this nodule, always look at the thyroid bed. And the key thing to remember is that if you make a mistake and they remove it, the patient will become hypothyroid. So at times, this ectopic thyroid might be the only viable thyroid tissue the patient has, just like in this case. There is no normal thyroid. So this is the location of ectopic thyroid, lingual thyroid. This is a case from our hospital where the patient presented with midline neck swelling, and there was a solid mass on an ultrasound. The report was that we should do an MR and we should consider biopsy, MDT discussion, blah blah. So on MR, this is the MR. In this case, the thyroid is normally seen also, and there is a bit of hypertrophy, and this is that tissue, just like the case which I showed you, it is going superior. The key point is that on all sequences, the signal intensity is equal to the parenchyma. And then you know your embryology, and then you can be very confident. So this, our case actually was ectopic thyroid, and I will quickly show it to you, and then we will go to the last case of the day. So here you are. Now, if you see here, this is this is the midline, this is the base of the tongue, and then this is the hyoid bone. We are going inferiorly, and here comes this nodule. Here comes, and look, it is very well defined. It is midline. It enhances equal to the thyroid. So in this particular case, the right lobe is visible, the left is not seen, but there is a bit of ectopic thyroid tissue here. Okay, last case of the day. So, madam,
Yes, doctor.
this is a 72-year-old male, pain epigastrium off and on since 2 years. The patient came to A&E. The surgeon wanted us to rule out mesenteric ischemia particularly. So we did a CT scan. So I am going to share it once again. Yeah, here you are. You can see it.
Yes, just I.
So you can ask for the mouse. This is last case of the day.
Okay, thank you. Request remote control. Sorry, doctor, I can't scroll. Could you please scroll it to me? No, no, I'm scrolling now. Thank you.
Just concentrate on the upper abdomen and forget about everything else.
Okay, this is axial CT abdomen with contrast, with arterial contrast for a patient presented with upper abdominal pain. Okay. The patient is presenting with epigastric pain, so I would like to check the epigastric area. I can see that the pancreas appear normal with no surrounding fat stranding, and no dilatation of the pancreatic duct. The gallbladder also appear normal. CBD appear normal for me. I can see that the stomach appear it's not filled, but there is circumferential gastric thickening, which I would like to follow. Yeah, okay, this is esophagus going down. Yeah, it is seen mainly in the fundus and the body of the stomach.
Right, that is one finding. Anything else?
I will scroll down to the duodenum. Also, there's also duodenal thickening, pyloric, and no, this is the pyloric, sorry, and this is the duodenum. Yeah, there's a enhancing lesion seen here within the duodenum. I would like
Where is the enhancing lesion in the duodenum?
here, this one. Can you see my pointer, doctor?
Is it in the duodenum?
It's extraluminal, but adjacent to the, I think this.
Adjacent to the duodenum. Okay.
Yeah. I will check the going down.
That's fine. So you have picked up two findings. What is your conclusion?
Okay, for the I in my routine practice I would like to check them in the coronal view as well. For the duodenal lesion appear extraluminal.
Here you are.
Okay, thank you. Yeah, there is the circumferential wall thickening of the gastric mucosa. I can see it, and this is suspicious for a malignant process. And I would like to scroll down to see the duodenal lesion. Yes, this lesion is seen enhancing medial to the second part of the duodenum. It is enhancing with central hypodense area.
So conclusion, madam. Conclusion.
I'm suspecting that this is a malignant gastric malignant process. Like to and for the duodenum, I'm suspecting that this might be leiomyoma or part of GAST.
Will it enhance like this?
Not really. For leiomyoma, it will not enhance like this, but maybe for the GAST.
Final. Give me the final diagnosis. We are out of time.
Okay. Guest. I would like to. This is my
Yes.
pre-part of the
Okay.
guest.
Thank you, madam. Thank you. You picked up the findings very well, but the eye see what the mind knows, right?
Yeah.
So the point is that I have This is a classical 2B case. This is a gastrinoma, Zollinger-Ellison syndrome. Let me tell you the background of this. Now, pancreatic tumors can be solid and can be cystic. I think 2 or 3 sessions ago, we did cover the cystic lesions. Now, solid lesions, the most common is the pancreatic carcinoma, and then there is pancreatic neuroendocrine tumors. Neuroendocrine tumors can be benign, they can be malignant. Now, this is from your book, Solid Pancreatic Lesions. Look at this heading. And this heading is a take home for you. Hypovascular, these are the lesions which are not, they don't enhance. Ductal adenocarcinoma, the classical pancreatic carcinoma, is low density. On the other hand, uh, hypervascular. And there is a, long list of neuroendocrine tumors. These are hypervascular. Now, one of them is gastrinoma, presents with multiple peptic ulcers, Zollinger-Ellison syndrome. Look for diffuse gastric fold thickening. The eye see what the mind knows. And this is what the exam is about, that 2 plus 2 makes 4, a unifying diagnosis. Please remember that majority are malignant, typically located in the gastrinoma triangle. So your eyes should be trained for. You picked up the finding beautifully, so well done for that. But you could not make the connection between the two, which include the head. And I'll show you a diagram to show this. This is what it is. When you see the neuroendocrine tumors of the pancreas, they can be hyperfunctioning and non-functioning. Now, look at the names: insulinoma, gastrinoma, glucanoma, VIPoma, somatostatinoma, ACTHoma, GRFoma, parathyroidoma, carcinoid. Now, look at the malignancy rate. The minimum is insulinoma. 10% are only malignant. Gastrinoma, most 60 to 65%. Some of them are close to 100%. Look at this, 100% malignant. But these two are most important for your exam, insulinoma and gastrinoma. Now, what kind of cases can come in the exam? If you know the basics, you can see what kind of cases can come. Gastrinomas are multiple in 60%. So once you pick up one, keep looking for second or third or fourth. They can be large. They are in the gastrinoma triangle. Develop your eyes to look at the gastrinoma triangle. So they can be extra pancreatic. How much? 15% of them. Key finding: they can be with 20 to 25% with MEN1 syndrome. So you should know the definition of MEN1. And they might give you a long case, or they might give you what we call a viva case. Now, this is the definition of MEN1. Pancreatic neuroendocrine tumor, right, is one of them. And look at this, parathyroid adenoma. Suppose they show you a hand film with a hyperparathyroidism, and with that a net, then you should understand that the final diagnosis is MEN1. So these things are extremely important to make 2 plus 2. I can even give you a meningioma with it, and you can say this patient might have MEN1, because then my questions will be clinical. What will you do? And you have to rule out all of these tumors. So for all of these tumors, I do not have time right now, but they will ask you, what will you do? And you have to think deeply that what kind of investigations are you going to advise? Ultrasound for something, MR for something, nuclear for something, etc., etc. So this is a case of insulinoma. If you look carefully, this is the SMV, and there is a hyperdense enhancing lesion at the head of pancreas, which was hypo on ultrasound scan. Please remember another thing, that neuroendocrine tumors can cause, other than hypervascular, they have got calcification. So usually pancreatic adenocarcinoma, unless it is over a background of chronic pancreatitis, might not have calcification. So this one is enhancing. Look at this calcification with enhancement on a plain film. So this is the viva starts on a plain film, and you can see this nodule. And what can it be? And you can say it can be in the region of pancreas, it can be adrenal, it can be whatever, mesenteric. Then they will show you a CT, and it might be an enhancing neuroendocrine tumor. This picture should be etched in your brain like anything. And this is an exam diagram from radiographics. This is gastrinoma triangle. So they can be within the pancreas, they can be in the groove, they can be outside the duodenum. Our case was sitting here, it was outside. It was infralateral to the duodenum, remember that. And all the way up here till the cystic duct. This is what we call, they can be inside the groove, they can be outside the C of the duodenum. So this is the key. And then 2 plus 2 makes 4. Look at the rugi. So this was rugal thickening, which I showed you. And this is a subjective type of a phenomena where you develop your eyes on rugal thickening. So this is another case where there is an enhancing lesion here, which is partly projecting into the lumen of the duodenum with some rugal thickening. And this is Zollinger-Ellison syndrome. There is another differential diagnosis in your book, gastric fold thickening. Please remember, on a CT scan, you have to, it can be tricky finding, but in classical cases, you will pick it up. Increased prominence of gastric folds versus, thickening of all of the wall. Zollinger-Ellison syndrome due to gastrinoma causing excess acid secretion resulting in multiple or recurrent gastric and duodenal ulcers both in D1, D2, etc. So this is because of response to excess acids. And with that, I will show you a case from my old collection. Look at this one. This is a classical exam case. This case presented 60 years old, clinical episodes of severe pain, abdomen, mesenteric ischemia. So we did a axial, non-contrast, and you can see this rugal thickening. I'll show you post-contrast. This is, and there were a lot of what we call calcification, etc., etc. Now, so this is a beautiful case, classical exam case. And then we have got axial arterial. Please remember we did a CTA actually in this case because of the clinical, they had asked for that. On this, you can see this enhancing. Now this is metastasis. This should be taken worrying for a metastasis. Carcinoid metastasis, remember, that also enhances on, and look, this is rugal thickening. I'll come back to this on post-contrast. Now, this is SMA, and sorry, the celiac artery, the SMA. And now the pancreas is coming into our, and here you are. You can see this enhancing lesion here. You can see this enhancing lesion. So this is corona. Look at this. This gives you rugal thickening on a CT scan. Look here, same thing. This is that enhancing lesion. And on a sagittal, here you are, you can see it very well, the lesion which I was showing you. On a portal venous phase, look at this. This is how rugal thickening looks like cerebri from like a, cortex of the brain, right? Brain gyri, that kind of appearance. And then you can see the washout on that metastasis. So this is a metastasis. And so this is Zollinger-Ellison syndrome. And this is the pancreas, and the lesion is sitting here in between, the pancreas and the duodenum. So with that, let's go through your case. So your case, you picked up the finding very well, so very good about that. First of all, I just want to show you the rugi. If you ask yourself, you have to develop your eyes on these things because, you can see how it gives you that cerebriform type of appearance. It's not classical thick wall, which will be more diffusely enhancing. So this is rugal thickening, but you picked up that finding very well. Now, if I go back to the axial and see it here, now this is the head of the pancreas. This is the D2. This is the head of the pancreas. This is the uncinate. So I'm coming towards, this is D2. And now comes the lesion. This is D2 and D3. Now here is the D3. You see this D3 goes there. So this lesion is sitting outside the duodenum, lateral to it and slightly inferior to it. Still, it is in the gastrinoma triangle, which I showed you. So this is the C of the duodenum, and the lesion is sitting outside inferior and slightly lateral. So this is gastrinoma with rugal thickening. Okay, well done. You picked up the finding very well. You could not just, join them together. So well
Okay.
done.
Thank you, doctor. Thank you.
Okay, now, the point is that next session will be slightly different. What I'll do is I'll select cases from uh, what we call temporal bone, base of skull, and maybe CNS. I'll see. But my main aim is to consolidate your temporal bone anatomy, and there is no better way than to see more on core cases of the same thing. So next session is going to be different. It's not going to be classical pot-pourri. It's going to be temporal bone, base of skull, or CNS, that kind of structure. Okay, then, thank you very much. Next session is next Thursday. Next Thursday. And temporal bone anatomy, there is, those of you who are juniors, uh, there is what we call there is no better way to keep reporting them. And then you will, I think the most difficult anatomy in the human body, as far as radiology is concerned, is temporal bone. And the more you will report, the better you will become. Okay, then, thank you very much. Let me share the feedback form. Thank you then, and good night.